psychiatrist, as you probably know, at SUNY Downstate. They asked me to do this session every year because I'm a subspecialist in physician health. And so what I decided to do this year to keep things current, because I have a slide set that I usually use and I update it each year that is specific to residents and fellows. But this year I thought I'd do something different, which is give you just sort of an overview of how things have been since the pandemic for people in medicine. So what I'm going to show you is a slide set. It's a presentation that I gave to the University of Nevada in Reno a month ago in December. And it was composed of medical students and residents and fellows and faculty there. So I think that you'll find that it's got relevance to where we are today. Okay, so let me just share that. Okay, is that coming up okay for you all?
It is.
Yep.
Yes.
Okay. All right. So I'll just go ahead with this. So I said this is a month ago. That's why here are the objectives that I sent ahead to them because they wanted me. Let me just go back here. They wanted me to talk about wellness, preserving wellness during the COVID-19 pandemic. Okay. So I'm going to start off with a definition of that. Enumerate the ways in which clinicians have been impacted and some of the solutions, which are pretty broad-based. Now, believe it or not, this is outdated because it's a month old. As you know, that's kind of how fast everything's changing. So this is why, and when I made up the slides set for them, this was already November 23rd, which was like 10 days before my presentation. So that's where we were then, with that many deaths worldwide, that many in the USA. I put in the deaths in Nevada because I researched that since I was speaking to a group in Nevada. And they told me that their deaths were actually going up quite exponentially at that time in Nevada. Those were the number of deaths in New York on November 23rd. So as we know, it's higher since then. New York City has gone up. And so that's why I said this uptick that was concerning with the cooler weather, pushing people indoors, kids returning to school, arriving flu season, et cetera, et cetera. And as you know, all of this keeps changing because there's so many different things that are occurring on a day-to-day basis as we fight this pandemic. So here's a very wordy definition of wellness. By the way, when I'm all finished, I think I'll just send this slide set to whoever, and then they can just send it around. Maybe that would be Victoria or whatever. Somebody can just let me know at the end.
Absolutely.
So that you can all have a copy of it and then just send it along. So as I said, the reason I put it down here though, was because this article in academic psychiatry, they were trying to figure out how are we ever going to research wellness when there's so many different definitions. So this is what they came up with. So it's quality of life, the absence of ill-being. Now, what I wanted to tell you, until about 10 or 12 years ago, when you asked anybody about wellness, all they would say was, well, it's devoid of illness. Like there's, if you're well, you're not ill. But as you know, it's much more complex than that. And so this is why this part is added, the presence of positive physical, mental, social, and integrated well-being. Okay, experienced in connection with activities and environments that allow physicians to develop their full potentials across personal and work-life domains. So as I say, it's a very wordy thing, but you can pick out little bits and pieces. Now contrast that with the WHO definition, which is easy to really remember, a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So that's what we're always striving for, is to attain wellness or preserve wellness in us as medical students, as residents and fellows, et cetera. So how have clinicians been impacted? So I've got a whole series of slides here that are not in any particular order, but it's how we're impacted professionally and personally. The National Academy of Medicine, and by the way, if any of you are wanting to study this subject more, the two go-to places that I use to get everything that's just hot off the press are the National Academy of Medicine. They have a phenomenal website, up to date. Yeah, I think it's updated, if not daily, twice a day, as well as the American Medical Association. I mean, because as you know, we're bombarded by so many different sites, so much information coming at us, but you can't follow them all. So if you ever have to kind of do a presentation or write a brief article or whatever, go to the National Academy of Medicine or the American Medical Association. Okay, so this is what it was like in our country before COVID-19. So it's presenting clinicians with even greater workplace hardships, moral dilemmas. I'm going to talk about that in a minute. Very likely to exacerbate existing levels of burnout and related mental health problems. So that's the link to that. Now, this was an article in Psychology Today, which was, I believe, I think it was last summer. I know that I was interviewed for this article just before the pandemic. So I think I was interviewed in February. The reason I put this up here is that this is a very well-researched article. The writer spent months on this, interviewing specialists in physician health all over the country. And so, again, if you're interested in this subject in some detail, I would suggest that you have a look at this article. It's a pretty graphic illustration, as you can see. Okay, are physician burnout rates going up? Okay, well, this, by the way, the reason why I wanted to put this piece up here is Dr. Jerome Groopman, who is the second author here, is a very well-known Harvard writer, physician, researcher, et cetera. But I took it from New England Journal of Medicine last summer. So with the pandemic, despite the uncertainty, a sense of altruism and urgency has unexpectedly catalyzed the restoration of some elements of autonomy, competency, and relatedness. Now, I can tell you that there's a lot of truth in that. I'm going to say more about this in a minute, but when Dr. Viss and I were running the facilitated support groups for the hospitalists and for emergency physicians back starting at the end of March through April and May, this is sort of what we saw. I remember one physician at Downstate saying that he had been feeling so burned out until the pandemic hit. Now, what he meant by that is that he's working hard and he feels tired, but he feels vital. He feels that his skill set is being used, that he's practicing medicine again, and not a lot of BS of stuff that he felt he was doing before. And so I thought that was a very interesting thing. And I've heard this from other physicians as well. Despite the uncertainty, despite the fears, there's a sort of sense, though, of using your training in a good way to help. Now, this is from our own, you may or may not know this, but our Department of Psychiatry at Downstate is involved in this national AMA survey. And this is all we had back in July. I don't have any updates since then. And this is a survey of all of downstate clinicians, and it's not just physicians or medical students, it's all of the health professionals. Okay, so, but you can see, so again, it's not a very big end, but 65% of the respondents were female. I'm not sure why that is, why there aren't more men responding. There's the racial and ethnic breakdown. Look how many nurses are responding to the survey, but very few doctors. And those were some of the symptoms that they were describing. Anhedonia, feeling down, sleep changes, flashbacks, hypervigilance, and avoidance. Contagion fears were very high. Now remember, this was July 2020, so we were just New York was just kind of being relieved of being the epicenter in that month.
Excuse me, Dr. Myers, do you know,
yeah.
I'm so sorry, Dr. Myers, do you know in terms of the respondents, if they had children or not?
I don't think that was asked on this. We were, if I don't have a copy of the actual survey in front of me, but the questions
I remember taking it, and I can't remember as well, but in terms of the overwhelming number of women, I would imagine that there are other sort of intersectional stressors and demands.
Good, very good point,
like
Tanya.
being a working mother and
Yeah.
also having to take, to do the remote learning.
Yes, yeah. Thanks for adding that, because we never know. I think when we're wondering about who responds and who doesn't respond, and because in research sometimes even people who are actually quite symptomatic don't respond. So in other words, it doesn't mean that they're all just sort of feeling well. I've heard doctors say before the pandemic, I'm too burned out to fill out another burnout survey. They kind of say it with tongue in cheek, but you know what they're getting at? It's that survey, it's, survey monkey fatigue, that sort of thing. But anyway, thanks for adding that, because it's very, very important. And the fears, all of the way that this has affected daycare, getting help, nannies, the whole, just the whole thing with school, having homeschooling, all of those kinds of things are all very important. So this is,
my apologies,
I'm sorry, go ahead.
Interrupting also. So is that the explanation for the seemingly lower response for physicians? 12% is significantly low, I believe. Is that the explanation? Fatigue? Survey monkey fatigue? Or is there another explanation? Maybe why?
You mean why there were?
There's another explanation on the survey data. And this is the percent of the respondents. So we don't know what the denominator is for each of these categories. So it could have been that only 12% of the total denominator were physicians. So it could be an accurate reflection of those demographics. We don't know that from the data. That's one of the problems with these kind of surveys. That you can do that, but it's complicated to do.
Okay.
I know. And actually, we've got a very, Jacqueline Myers in our Department of Psychiatry is looking at this much more closely. And I think we'll have a more accurate representation, from a scientific standpoint. This is all pretty anecdotal here. So this was just a narrative written by one of our nurses. That really speaks volumes. I wanted to include, for those of you who weren't here at the beginning, this is a slide set that I used in Nevada a month ago. They haven't been hit as hard as we have, although who knows what's happening there now. With regard to substance use disorder, we don't, anecdotally you hear about this, but I don't have any studies at my fingertips of substance use disorder in clinicians. So physician suicide, anecdotally, yes, but it's too early for longitudinal research. This is something that I follow, pretty closely. But it's something important to remember here is Emil Durkheim, who was famous for his social integration theory. When people are supportive and pulling together, the rates may not go up of suicide because it's got to do with isolation, estrangement, loneliness, et cetera, et cetera. And that's why we've been worried about this with regard to shelter in place and social distancing for those individuals who are already quite isolated. This has compounded their sense of isolation. But for other people, though, they feel more vital than they have before. The third bullet is extremely important because, as you know, this virus is still mysterious in many ways, and we're obviously learning much more now about the after effects and long-term sequelae, especially to the immune system. In our branch of medicine, and sort of the neuropsychiatric complications are really concerning. And in fact, I'm going to wait, I'll come to that in just a minute. And we know this is the piece that addresses the psychosocial economic fallout being huge, the inequities, job loss, et cetera. And all of this is still going on. So this paper here, the reason I wanted to put in it, because at the time it was so recent, in occupational medicine, is that I'm going to talk about moral injuries in just a second. There's still this reluctance of physicians to use the support helplines that we've even offered at SUNY Downstate. like for instance, to my knowledge, the only groups that are still running are the ones for nurses. All of the ones for physicians, medical students, and residents are paused. Anyway, they recommend the peer groups as well as clinical ethics committee, and that would sort out a lot of decision making for doctors on the front lines. So if you're not familiar with the work of Simon, I think is Wendy Dean and Simon Talbot and Arthur Kaplan, this is a very important paper because they shine a light on the Moral Injury Center that's been set up in Washington, D.C. And these researchers are calling for a whole redefinition to get rid of the word burnout and call it moral injury. Now, what this is the moral dilemmas are the things that we first confront, usually in medical school, things that are pretty common, where you're in a moral decision about some clinical thing, and that's usually where you get a consult from ethics or something like that. Moral distress is when we're in a situation where we feel really upset about what's happening. At the very beginning, with concerns about PPE, as well as reusing gowns, not being properly protected, those sorts of things would contribute to a sense of, or having to make decisions, for instance, about ventilators, who gets this, who gets what, that sort of thing. That all contributes to moral distress. Moral residue is what's left over in you that kind of sits with you. And then that leads then to this sense of moral injury, that I just can't do this work any longer. It's making me ill or something like that. And that's why, to prevent these sort of things and to get help, it's so important to have groups and to have consultation as well as discussion. So what I have found is, what we set up was something both one-on-one for downstate. We've got this thing called UpDocs, where any downstate person can talk to a mental health professional. That's one way where I've seen some individuals at downstate, talk about the way they're feeling, but you can see that moral injury or moral residue, is embedded in some of their symptoms. So you remember, I don't know if you actually saw this in the New York Times, this article that with this title, One Rich New York Hospital, by the way, which is Mount Sinai. Warren Buffett's help, this one, which is SUNY Downstate, got duct tape. And Dr. Frange was quoted here, aging crumbling facilities. Why shouldn't this I thought was one of the most important sentences in his interview. Why shouldn't an African-American have facilities that are at the same level of other patient populations, he said. Okay, Saturday, March the 28th, I don't think we're ever going to forget that, because that's when Governor Cuomo designated UHB as COVID only. So that weekend then, Dr. Fanucci's our chair in the Department of Psychiatry, and Ms. Gableman, and a bunch of the rest of us, we worked to get these services set up, anticipating that with a COVID only hospital, this is going to be very stressful for our frontline workers. And so that's what we did. We set up weekly support groups for hospitalists, emergency docs, residents. Those were daily. At various times of day to accommodate residents, groups for medical students. Then after Dr. Mahoney died, we set up a single group on May the 7th for critical care, pulmonary doctors, 2 groups for nurses, and EAP across the street with Dr. Ali Jensen. So this is the UpDocs thing that I was referring to. That's how there's a stress hotline as well as texting that accesses that. And here's some of the themes that we published in an article that Dr. Viss and I and Dr. Fanous put together about our support groups. So as you remember at the very beginning, there was such a high worry about contagion to the workers themselves, of course. Am I going to get sick? Am I going to give it to my peers? I'm going to give it to my family. And that's why some of you who are maybe even here on this, in this program today, decided to stay at the hospital or in a hotel and not really even see your families at that time. So that led to a sense of social isolation. A lot of the doctors talked about these dehumanized interaction with patients because of all of the protective gear, so many different masks, things like that, the loss of intimacy in the normal doctor-patient relationship. And they felt so robotic-like in conveying bad news. I remember one physician talking about putting his name tag with his picture on it, his ID, in a plastic bag so that at least he could hold that up for the patient or the family member to see that behind all of this equipment, was a smiling or a happy face or a human being, these kinds of things. Those are, these barriers. Patients dying alone, so very, very hard, heart-wrenching for physicians. I mean, we're kind of used to this, relatives being at the bedside. And as you know, all family members at that time were outside the hospital, communicating on FaceTime with their loved ones in the hospital. So this lack of control and sense of futility. One of the ways that Dr. Viss and I tried to help with that, especially with the intensivists, the hospitalists, the emergency physicians, all of whom, have treatment algorithm for things and the use of technology. And we're finding that they couldn't use much of that. And we reminded them about how much of medicine is the human interaction. And that was very important, that what they were doing just by showing up, by being present, by not abandoning the patient, by trying to communicate hope as much as you could, was extremely important. Even though at that last prognostic uncertainty, because that's the way it was at that time. I remember one doctor mentioning that a patient said to him, "Doctor, am I going to die?" And the doctor responded to him with a statement something like this: "We're going to do everything to help you." Something like that. And he was kind of agonizing about that response. He got a universal sort of heads up from his peers that they thought that was really a very clear and hopeful, caring thing to say to a dying patient, who, by the way, did die 2 hours later, and wondered if he should have said something quite different. But we basically said that for somebody who was that sick, that they probably received some sense of comfort or support from a statement like that.
This was Dr. Myers. I'm sorry for interjecting.
No, that's fine.
Yeah, this was and is a very difficult period for many.
Yes.
I can identify with a lot of the bullets on the previous slide. In almost 20 years of clinical practice, we encountered things that, there was no precedence and no protocol in terms of how to approach it. I remember clearly one of my most difficult, for lack of a better word, interaction with a family. One morning my team, we had to pronounce, and I was rounding with two fellows at the time. We were all redeployed to cover inpatients. Yeah. And we had to pronounce a patient who, I'll put it in quotes, unexpectedly expired in the context of COVID. And, I elected to, there are times when the intern or the fellow would make the call to the family to inform the family, but I elected to let me handle this as the attending. And, again, there was no precedence. It was one of the most difficult conversations to have. I mean, in terms of informing this daughter of, that her mom had passed away, had expired, there was such an agonizing, heart-wrenching scream from the other end of the phone. And you're in awe because how do you respond to that? And so you pause for a while, and then the next statement is, I want to see my mother. And of course, no one is allowed in the hospital. No relative, no family member is allowed into the hospital. And in fact, it is the funeral home that is given access and so on. And even that takes a long time before the family can get to see. So it was a very, very, very difficult time, and it still is, in terms of patients at the nursing homes and so on, family members not able to see their loved ones. So I appreciate this kind of work. It's a very difficult time, and
I appreciate your work, and I appreciate what you just said, what you shared with us, because this is exactly what is happening. Just so with no precedent, no skill set, and just doing your best, and then having to, as you say, to say, well, I'm sorry, you can't come into the hospital. I mean, we're just not used to that. It's just, we can't help but identify and think, oh my God, wonder if this was, my mother or my grandmother or my son or something. I mean, it's just,
And
it's this type of, yeah.
Oh, I'm so sorry. I think there's always a delay with me. I apologize, Dr. Myers. I wanted to piggyback off of what Dr. Prosper said, which is, so I just pulled up your article, but I'm also thinking about the impact of health disparities, and the fact that more Black and brown folks knew who unfortunately died. So the burden of this particular of mortality was higher among racial and ethnic minority folks, including our physicians. I can think of one here at Downstate who lost two family members who were both physicians, and one was quite prominent up in the Bronx. And so I'm also wondering that thinking about this impact, that there are other lenses that could also reflect in terms of the the malaise in the fact that sort of there's so much racial injustice prior. I'm just wondering if the cumulative impact was not just the fact that we knew far more people dying and had that particular experience, but that it was also complicated with racism and social injustice and feeling threatened in other ways in terms of the racist rhetoric that was circulating in our country prior to that. So I think that, thinking about it within the historical context, there were so many stressors on so many people that I think that that those particular lenses, and also looking at in particular sort of the impact on women, working women, and what happened when the schools shut down, I think is also something that really needs to be looked at. So I didn't get a chance to read your article, but I'm very, very curious, and I just wanted to add those two bits in terms of race and gender, in terms of the intersectionality and the impact.
Thank you. Thank you. Yeah. You had a chance, I'm sure, to read the content of this slide already. And that's been very, very, very difficult. And the symptoms that break through, the grieving is profound. It's going to continue. I mean, grieving goes in stages. But I remember, again, in those early days, one of the doctors, I think from Kings County, saying they're used to death, but not so many on one shift. that sort of thing. These are quotes from our groups. My heart aches, my chest is so heavy and it gets heavier as the day goes on. I can't wait to get all my equipment off and just weep. The last 2 days, I think I've lost a pound, all tears, just crying. So sad for people who were my patients for such a short time and their families. I write a blog every 2 months for Psych Congress. And so I put some of these things in there as well. You know, just that it's got to do with representation, actually, that these things are very important. When Dr. Prosper was speaking, I was struck too by just the use of your language, you know, that it was from the heart and from the soul and the gut. And that's the thing that I think we've noticed through this pandemic, that physicians are using much more what I would call affective or emotional language to describe their feeling states. And there's less of the character armor and the, I don't know, the intellectual jargon that we use in medicine to distance ourselves. I mean, as you know, it's protective. We use it to communicate with each other, but sometimes it can, you know, it shields us when we need it, but sometimes it can become hypertrophy. And I've just felt through this pandemic that people are just speaking just much more openly and much more authentically. And I think that's important. I think it's healthier to be that way and not to worry about, quote unquote, losing it or something like that. I took this picture in our cafeteria because many of you probably saw it. It's a wonderful memorial to Dr. Mahoney, who touched the lives of so many in the many years that he was active at Downstate. What we did when Dr. Lorna Breen died is that every year, some of you may or may not know this, but this past fall was the 3rd annual National Physician Suicide Awareness Day. So I contacted her sister, Jennifer, and her husband, Corey. They're both attorneys. And we had a Zoom band rounds that day. Some of you might actually have attended that because it was by Zoom. But I called it Harnessing Suicide Grief into Action because these two have become very active in Washington. And there's been a bill endorsed, signed on by Senator Tim Kaine from Virginia, the Dr. Laura Breen clinician act or something like that that's going before Congress to basically look at stigma that prevents so many health professionals from getting life-saving care, as well as, you know, working to make sure much more education in this area, and basically, you know, offering just sort of more help and support for health professionals. So they're amazing advocates, and they've, you know, in their grieving because Dr. Breen died in April, and many of you know the backstory that she had never experienced any psychiatric illness or problems before. Was the head of emergency services at the Allen Hospital, part of New York Presbyterian. Got COVID herself, was off briefly, I think, for 10 days, went back to work, but she was not well and deteriorated rapidly into what looks like some sort of a neuropsychiatric mood disorder, affective disorder, which was relentless, and she died by suicide. Tonya, is that your hand up? I didn't know.
Yeah, yes, it is. I'm just wondering, in light of what we are starting to learn about the neurological damage that COVID does to the brain, and that people are starting to report sort of psychoses or mental health issues,
yes,
that maybe her suicide was an early sort of warning, and that
yes,
we need to be cognizant that it could have been the context of the horrible work that just the horror of what people were seeing in the EDs, but that also it might be actually the impact of the virus. I remember at the time I watched an interview with her family, and her family explicitly commented that they thought that their daughter had changed as
Oh,
a
yes.
result of the
Yeah.
virus.
Oh, no, absolutely. I've come to know them quite well, and they really do feel that she developed a brain disease. What we don't know anything about is the actual care that she received at the University of Virginia. But I know that they were awaiting postmortem findings and things like that when I last spoke. But no, I think that this, right. And also, some of you may have seen a piece, I think it was in the New York Times, but it's been reported in the medical literature about the quite distinct psychiatric presentations that patients are bringing into emergency rooms, as well as, to primary care physicians and then on to psychiatry, which really looks like some type of brain syndrome, often without delirium, but certainly new delusions as well as specific types of hallucinations. So that's all being researched and studied too. So this is just, again, from one of my blogs about social media and donating to advocacy efforts and things like that. I wanted to just mention a little bit more about loss. These ways families unable to say, this is all things that we've already kind of touched on. And this pervasive sense of helplessness. People are often at, what can I do? What can I do? Dr. Plakin, who's a psychoanalyst, actually has written about COVID-19 and blocked mourning. So it goes all the way from our masked relationships with each other as a substitute for authentic human closeness that people are missing because you can't see people's mouths, for instance. Interact with our children, access to funerals, graduations, weddings. I have a new book out that was in the President's Bulletin called Becoming a Doctor's Doctor, a memoir. And in my concluding chapter, I talk about attending a virtual funeral for a colleague of mine, a psychiatrist who died of COVID-19. And that was just the reality back in May. I think there are some funerals taking place more now in person, but most of these things, graduations, weddings are virtual. And just this uncertainty that we continue to live with. And Sean Joe, who is a colleague of mine, an African-American psychologist who works in the Midwest, he's been writing about the grief in African-American men, especially, for decades now. And he talks about this. These are some quotes from his paper that we'll see a vast amount of grief and emotional trauma blossom throughout the nation. No time to say goodbye is basically, I think, a very apt word in terms of this grief. But on the more positive side, this is why I wanted to put up this slide. There is a sense of solidarity and camaraderie that I think is nice. Open to expressions of caring and concern for each other. People asking, as you know, this is the time now that people are asking, are you okay? And also listening to that answer. And if they're not okay, coming back to it. Are you sure? That sort of thing. Emotional language that I talked about in a minute, what I call unbridled disclosure of feelings, less medical jargon, fluidity and medical hierarchy of attending physicians and trainees. That I think is refreshing. I think there's still the sort of sense that so-and-so is my attending physician, but it's not quite as formal as it was because everybody is sort of dealing with these issues having to do with, for the first time, grief and things like that. So I think it's a good thing, actually. And to me, it doesn't obscure the hierarchy and the power differential of the teacher-trainee relationship at all. In fact, I think it strengthens it. Some people who have felt guilty because they're not on the front lines, you're not alone if you feel that way. Some of obviously practicing medicine virtually, advocacy work can be so helpful. I've put all these, I take a lot of these stuff from JAMA and from the New England Journal of Medicine. So again, you'll have all of these slides. So pay attention to yourself first. That's this whole sort of thing that, you know, we have to take care of ourselves if we're going to be of any help to anybody else. Talking, paying attention to each other. Don't worry about boundaries, reaching out to a colleague. That's why this last bullet, I've crafted these words pretty carefully. Shake off those reservations that you're intruding, that it's none of your business. You may save a life. That's one of the things that we're finding now more than ever, that simple acts of kindness can actually save lives. You know, it doesn't have to be anything fancy. It's just people noticing each other, reaching out, and caring. These are, this is the American Psychiatric Committee on Psychiatric Dimensions of Disaster. So these are all of the basic things that you're all doing and have been doing, I'm sure, right from the beginning of the pandemic. And this is just more of a checklist. By the way, I want to just jump right down to the last one for a moment. Honor service, remind yourself and others of the important work you're doing. Recognize colleagues for their service whenever possible. As you know, many people on the front lines don't like to be called heroes. You're our heroes, that kind of thing. But yet, the individuals who were out on our, out on our terraces or out on the street every day at 7 o'clock, playing music and banging pans and clapping, that was a ritual. I think that not only was it sort of nice to see and to hear, but I think it was necessary for those individuals to do. And so, even if you don't feel like a hero, that's okay. If they need to call you a hero, that's okay too, that sort of thing. So, because they're just expressing a great deal of respect and gratitude for the work that you do. So there's 4 key elements that seem to work well in the pandemic. One is leadership, and we're blessed, I think, even despite the fact that not everybody agrees with everything, who would, of our governor. Having Governor Cuomo through this pandemic actually has been a godsend in many respects. Many states in this nation have not had somebody with that kind of leadership, all right? And then, because then it goes all the way down, right to downstate, of course, is President Riley's been wonderful, and just so many of the other individuals, Dean Brunicardi, people who are in leadership positions, department chairs. The communication is essential, education, infection control, and mental health. I remember having to say to people right at the height of the pandemic that when you go home, you're exhausted. It's probably best if you don't watch CNN, because I think it was just like too much stuff coming at you. It's maybe you need to watch Netflix or something, just go for a walk or whatever. You'll get updated about what's new with the virus through your work. And then social support. One of these things that for all of the residents and fellows who are on this call, it's been very hard, I think, for our new residents, especially at Downstate, who started last July, right in the middle of the pandemic, because so much is virtual. And there isn't, I was talking with somebody who said there isn't the TGIF stuff so much now on Fridays, or the weekend social events that were kind of so common when people could meet up in a bar or go to a baseball game or have a picnic or things like that. You know, people are doing some of these things virtually, which do help, but other things, though, are really concerning. And I think that's why we can't wait again until, you know, restaurants will be reopened. These are just things about moral injury. This is my colleague, Dr. Peter Yellowlees, who is also a specialist in physician health at UC Davis. And he's an expert in telemedicine. And he's been doing telemedicine for, I think, more than 20 years, long before the pandemic. And also has explained a lot of things too about the moral injury that he's seeing. He's a health, a chief wellness officer at UC Davis, where they have a dedicated position there. PTG, by the way, is post-traumatic growth. You know, we hear a lot about post-traumatic syndrome, but people also do grow through trauma. So that's the positive psychological change with this sort of new normal. And these are the 5 dimensions of that. Deeper relationships, openness to new possibilities, greater sense of personal strength, stronger sense of spirituality, and greater appreciation of life. Now, by the way, any of you who are attending today who have been through some sort of major crisis in your own life, it could have been, a terrible loss, bereavement of a family member or a close friend, or an illness yourself that you've survived, some type of traumatic experience, and you've come through the other end with growth, will know exactly those things because you're changed. You are very different after something like this. I work in the area, and my research is in the area of suicide bereavement. And I can't tell you the number of people I've met who have lost a family member to suicide, and how they've gone through that very painful journey that can take years, but they are very, very different people. And they describe themselves in such evocative language. And they're actually just wonderful people to be around because they're just so, I don't know, they're just so smart, they're wise, they're caring, very little narcissism. And that's always refreshing. The physician support line was started nationally, and I wrote an article about this because I was so impressed that over 700 American psychiatrists have volunteered on this physician support line.
Yeah, I'm getting notices that I'm supposed to fill out some forms, and I'm not quite sure what forms.
Oh, I'm sorry, who was that speaking? Is it referring to this? Or was that something else?
Dr. Myers, I think that's a hot mic.
Oh, okay, I'm
Yeah,
sorry.
that was a hot mic.
Oh, okay, all right. And let me just finish with this. I live in Harlem. I live right across from Harlem Hospital Center. And as you know, it's a safety net hospital too. And so during the late summer and fall, this beautiful piece of the outdoor art show in St. Nicholas Park was erected. And I found myself going there a lot through the summer and fall, right up until, the weather got cold, wayfinding. I just wanted to show 3 of these pieces. How much of care is patience? I thought that's so relevant to our health professionals. How much of love is attention? How much of life is coping? Those are just the 3 of I think there are about a dozen panels. And this is what I told you about earlier. This is how I started with a personal anecdote. Well, I'm going to read just a little bit of that. This church is being closed because of the pandemic. The service began with a blessing outside of St. Teresa of Avila in Summit, New Jersey. Drew's companion, Rosemary Dackerman, spoke a few words outside. An hour later, the service resumed with internment of his ashes at Christ Church Memorial Garden in Short Hills, New Jersey. The minister said a few words, as did Rosemary. She invited anyone attending by Zoom to speak, and many mourners did, including myself. Several voiced their frustration and sorrow at not being able to be physically present to hug her and Drew's family and close friends, yet their sweet memories of Drew as a kind and caring man and physician eclipsed the physical distance imposed by the virus. It was remarkably intimate. Anyway, then I go on to talk about that more. I want to close with this. Many of you, the name of Dr. Paul Kalanithi will be familiar to you because of his wonderful book that he wrote just before he died, When Breath Becomes Air. This was for those of you who don't know, he was a very young neurosurgeon who died of lung cancer just at the end of his residency at Stanford. And he was a new father at that time. His widow, Dr. Lucy Kalanithi, has done a TED Talk. And for those of you who haven't seen it, I urge you to have a look at it. It's extremely inspiring. And again, I think it epitomizes how we're changed by massive loss. And she is just an amazing person. Okay,
Thank you so much, Dr. Myers.
sure.
Oh.
Thank you.
I wanted to also add Arthur Kleiman. I think this was one of the
Yeah.
last in-person, in vivo sort of things that I ever did. So Arthur Kleiman, maybe folks might know, but like he's an anthropologist. He's also a psychiatrist. I'm
Right.
a medical anthropologist, and so his work is the fingertips of Arthur Kleiman are all over my work. And
Nice.
previously, like right before stuff started getting ugly, and I can't remember if it was early January or whatnot, but Dr. Kleiman was promoting his new book, which is called The Soul of Care, The Moral Education of a Husband and a Doctor, that was similar, I think, to what Dr. Myers was talking about with the widow